So this is an important topic. Let's make a start. And I believe you are able to share the screen, or the secretariat can put your slides on if you have slides. So there they are. And let's go. This is a very important topic in interprofessional education. And then you are talking about HIV, which is still become a chronic disease. We failed to get a vaccine for it, but we got a vaccine for COVID so quickly. So please tell us how IPE can support healthcare.
Okay, I guess I can start.
Please.
Okay, thank you very much, Prof. My name is Edward. I'm presenting on interprofessional education, IPE, in HIV care among healthcare students and practitioners in Ghana. I'm doing this on behalf of my co-authors from Kwame Nkrumah University of Science and Technology. By way of outline, this is what we have. By way of background, interprofessional collaboration, IPC, improves patient outcomes and provider satisfaction. IPC could have high impact in resource-limited settings with high HIV burden. Targeting interprofessional education.
Maybe your slide, you are talking maybe to another slide.
Can you please project it as full for a slideshow mode?
Yeah, slideshow, and then move the slides.
Yeah.
Are we on? We are not on the background slide.
Not yet. No, we are just on the headline slide.
Oh, I'd moved it.
Okay.
Let me see. What do I do?
Or you can stop sharing and reshare again.
Okay, so let me do that. Sorry.
All right.
Stop sharing. Share again. Okay, so I'm here.
And then you can put it in slideshow.
So
slideshow
this is on slideshow now.
Click the arrow on the right there.
Okay, is it changing?
Box.
Is it changing?
No.
No.
Oh, then I don't know what's happening.
Okay, let me project from my end.
Maybe the secretariat can.
Let me project from my end.
Okay, that's fine. So I'll stop sharing.
So whilst they are projecting your slides, just note that you have 10 minutes for the presentation.
Yes, please.
Yeah, and it goes to all the other presenters as well.
Hello, Dr. Dassah is ready.
Okay, I'm having, okay, no problem. I think I'll do it this way. So, okay, so You're on the outline slide now, is that correct?
Yes, you are on the outline.
Okay, so this is by way of outline. Please, next slide.
Yeah.
Okay, so by way of background, interprofessional collaboration, IPC, improves patient outcomes and provider satisfaction. IPC could have high impact in resource-limited settings with high HIV burden. Targeting interprofessional education, IPE, at the pre-service level and early career professionals is also likely to be of high impact. Studies on IPE or IPE training, especially among pre-service tertiary students, is novel in Ghana. Next slide. Professionals. Next, please. What did we do? We conducted pre and post-training online evaluation surveys among the participants. The participants were final year university health profession students and healthcare providers undergoing a 2-day interactive IPE training in HIV care from November 2019 to February 2020. They were trained in groups of 60 to 120. And within those groups, we had subgroups of 8 to 12, making sure that we had an appropriate mix of all the professions. The institutions involved were the Kwame Nkrumah University of Science and Technology, KNUST, and Presbyterian University College, Agogo. The clinical sites where these trainees or practitioners were having their training or practice were Komfanoche Teaching Hospital, which is a PEFA size, Agogo Presby Hospital, and 4 district hospitals in Kumasi, which were all PEFA size. Next slide, please. The content of the training was basically 8 striped HIV models, and these were, or they included initiating antiretroviral treatment, HIV and other comorbidities, HIV and tuberculosis co-infection, prevention of mother-to-child transmission of HIV, post-exposure prophylaxis, ART adherence and virologic failure, adolescent with perinatally acquired HIV, and pediatric patients with HIV. The ones in green are core models that were taken by all striped schools, not just the one in Ghana. And then the black ones, you had the opportunity to choose which models you wanted. Training was done in small groups involving discussions, interactive sessions, and role plays. Each module was delivered in about 1.5 to 2.5 hours and sought to emphasize interprofessional engagement, teamwork, and quality improvement. Next slide. So this is a training session. Next slide. Yes, so before the main training, we had a trainer of trainers workshop. This was also a 2-day interactive training, very much similar to what we did for the participants, the same concept and models. All together, we trained 30 facilitators comprising 14 females and 16 males. There were 12 faculty and 18 experienced HIV care providers. The proportions or the numbers of the other profession or the professions are also shown below: medical doctors, nurses, pharmacists, physician assistants, and medical laboratory scientists. Next slide, please. What did we find? Next slide. Overall, 833 participants were trained, and you can see the composition. CAF is Komfanoche Teaching Hospital. We had nearly 2/3 coming from there. Presby Hospital, Agogo, we had about 30%, and then the other PEFA size was about 5.5%. In terms of the levels of training, we had a pre-service student, they comprise almost 60%. Postgraduate, that's within 1 year, that is house officers, interns, these were almost 28%. And then for the postgraduates, that are those that are fully qualified, licensed, and working, those were about 13%. Next slide. What were the outcomes of the training? So overall, the post-test median score was significantly higher than the pre-test median score. And you can see the p-value is very, very significant. Now, in terms of the training sites, those that were being trained at CATH or KNUST, the difference between the post and the pre-test median score was also significant. Now, from those from the PEFA sites, though there was an increase in they would have gained some knowledge. We are not surprised we didn't find any significant differences. Now, for those that were from Agogo and then Presbyterian University College, we didn't find any significant difference in the post and pre-test median scores. This was a bit surprising to us. We are not entirely sure, but we attribute this probably to the facilitation and also the fact that they didn't have the full complement of all the professions during the training. In terms of the training level for pre-service, we had a significant difference. Postgraduate intern, there was a significant difference. And postgraduate, those that were already practicing, we didn't find a significant difference. And we were not surprised too, because here these are people that have been working in HIV largely. So we were not surprised with that result. Next slide, please. So this is also the display of the median scores by profession. And just to point out, with the exception of the last one, which is other, that is a physician assistants, for the same reason that I gave earlier about facilitation and the fact that they didn't have the right mix, we didn't find a significant difference, but all the rest, the differences were significant. Next slide, please. So what did our trainees think about the facilitation and the modules as a whole? So in terms of the facilitation, over 80% of the trainees, at least 80% of the trainees thought that it was extremely effective for all the 4 modules, that is module 1, the core modules. Now, over 90% thought that the facilitators were extremely knowledgeable, and over at least 98% thought that the facilitators encourage IPC between trainees or emphasize quality improvement in practice. Next slide, please. Of them were satisfied with all the 4 modules, and over 90% thought that the role plays were very effective. Next slide. To conclude, we would say that IPE improves health students and practitioners' knowledge on HIV care. Participants were satisfied with the training and the emphasis on IPC and quality improvement. What we need to assess is the clinical impact of the training that we've had. So to my acknowledgement slides and thank you slides. Next slide, please. So by way of acknowledgement,
in time, that's great, despite the small hitches we had at the beginning. I think we hear the other presentations and then we discuss them together. Can we have the next presenter, please?
So we
Are
have
they there?
Velisha. Yeah, Velisha can come next.
Okay.
Unfortunately, Prof, we are missing 2 presenters. They are not on the they are not on at the moment. So we hope that probably by the time Velisha finishes, they might join.
Oh, okay, that's fine. Let's go with Velisha now. And we have received an apology on the chat from the other co-chair But let's carry on. So far, so good.
Thank you, colleagues. Good afternoon, everybody. I am Dr. Perumal-Pillay from the Discipline of Pharmaceutical Sciences at the University of KwaZulu-Natal in Durban, South Africa. And today I'm going to share with you the results of a study that we conducted to evaluate the implementation of the Standard Treatment Guidelines and Essential Medicines List at public sector healthcare institutions in South Africa. Okay, South Africa is a middle-income country with a population of approximately 56 million people. We are in a democracy from 1994, yet there are still historic inequities in healthcare. To improve healthcare outcomes, the Democratic Government of South Africa developed a national drug policy, and this was implemented in 1996. This led to the development of the National Essential Drug Program, who was tasked to develop a standard treatment guideline and essential medicine list. Now, the standard treatment guideline and the essential medicines list was developed taking into account the prevalent health conditions in the country and a rational drug selection process. So the tool then led to a limited number of medicines being selected for this burden of disease in the country, which led to efficient allocation of public health financial resources, should have streamlined supply chain processes and increased accessibility to medicines. However, despite the implementation of the NDP system, the public healthcare sector, which caters to 80% of the population, and the private healthcare sector, which caters to 20% of the population. Thus, the country is moving towards universal health coverage through the National Health Insurance Funding Initiative. Now, the Standard Treatment Guideline and the Essential Medicines List tool features prominently on the NHI package of benefits. Therefore, the correct use and implementation is thus very important. The picture on the left shows you the hard copies of the books of the Standard Treatment Guidelines and Essential Medicines List from their time of inception in 1996. These were actual books that were used at facilities. The picture on the left shows the new free mobile application called EML Clinical Guide, and that was introduced in 2015. And that is now the latest edition of the Standard Treatment Guidelines and Essential Medicines List. So that's the soft copy. The purpose of the study was to evaluate the use and implementation of the Standard Treatment Guidelines and Essential Medicines List by prescribers at a public tertiary institution and its associated primary healthcare facilities. The study aimed to provide feedback and make recommendations to policymakers to improve the use and implementation of the tool and to inform NHI policy development. Now, the study was conducted in one tertiary hospital and 13 associated PHC facilities in the Umhla-Tuze sub-district in the King Chetsuwayo district of KwaZulu-Natal. The tertiary hospital also functions as a level 1 and level 2 hospital and caters to referrals from 18 hospitals in the northern KwaZulu-Natal region. The study design was an observational, quantitative, descriptive research design using 3 tools. So the first of this was a prescription audit tool, which was used to measure standard treatment guideline and essential medicines list prescription compliance and rational use of medicines. A survey, which used a questionnaire tool. This was self-administered and determined the knowledge and utilization of the tool by doctors and nurses. And the third was a tracer list tool. This is a benchmark in the country used to measure the number of key medicines available in our study. Now, the data collection tools were piloted and no changes were required. Data was collected in January and February of 2020. All sample size calculations allowed for a 5% margin of error with a 95% level of confidence. And the samples here, we had 107 doctors and 98 nurses included in our sample, according to inclusion and exclusion criteria, and the total number of 147 doctors and 134 nurses. The prescription audit sample size were 37 doctor scripts and 263 nurses scripts that were audited from 6,635 prescriptions at one hospital and 46,966 scripts at the collective 13 primary healthcare institutions, and these were scripts per month. Now, participants were recruited on a voluntary basis, and they participated after invitation and after informed consent. The data was analyzed by a statistician using SAS software. All ethics approvals were obtained for the study from our University Research Ethics Committee and our provincial, KwaZulu-Natal Provincial Department of Health Research Committee. Informed consent was sought from each participant and participation was anonymous. Data was kept confidential, password protected, and only accessible to the researcher. So we had a response rate of 97%. So 107 doctors participated and 98% nurses, 98 nurses participated. The prescription audit, as I said, we had 37 prescriptions by doctors and 263 prescriptions by nurses audited in the study. The two-tailed value of P less than 0.05 was considered to indicate statistical significance. The tracer list tool audit showed that all facilities had between 93 to 100% availability of tracer medicines from the 33 items that were listed on the checklist. This graph shows the summary of the results of the evaluation of the STG and EML in percentages. Now, if we look at the first set of bars, green is indicative for the results that we obtained for doctors and blue for nurses. So the first set of bars showed us that doctors were the ones with most access to the latest STG EML, and this is the app, okay, not the hardcover book, but the app. So that they would need to use at the facility. The second, third, and fourth bars show us that nurse guidelines and prescriptions that adhered to the STG EML. So they use the medicines that were listed there. This low set of bars shows us the poor training of the use of the STG EML. So it shows us that 10% of doctors and 17% of doctors received formal training on the use of the tool. The next set of bars shows us the knowledge on the use of the STG in EML. And here we can clearly see that doctors were more knowledgeable on the use of the tool as opposed to nurses. And then that corroborates well with the next set of data, which shows us that nurses, indicated by the blue, really wished to receive more training on the use of the STG and EML. The last data set shows the number of buyouts for non-EML items. So that shows that doctors wanted 5.4% of medicine in EML by prescribers. And as you can see, the nurses often used the STG EML and the doctors sometimes used the STG EML. No one never used the EML, so it was always an implementation at some point. So the results then show us that there was suboptimal adherence to the standard treatment guideline essential medicines list tool by all prescribers, as we saw adherence was less than 80%. This was largely due to the lack of recording of diagnoses in patient records. And our recommendation is for the National Department of Health to devise and implement strategies to monitor compliance to STGs, EMLs, or if such strategies are already in place, to then enforce them so that we are able to monitor the use and implementation of the guideline. We also recommend that reasons for non-compliance be investigated. That fell out of the scope of this research, but it would be interesting to know why there was non-compliance to the STG and EML. The results also showed there was a lack of training on the STG EML, and we recommend again that the Department of and the primary healthcare level is extremely important, as primary healthcare is the first port of call for most people seeking healthcare in the country through the public sector. The tracer list tool audit told us that essential medicines are available to effectively treat the prevalent health conditions as per the treatment guidelines, and some challenges with accessing the latest STG in EML, which is only available as a soft copy and as a mobile app were experienced by some participants in the study. Our recommendation for this is for the health department to reintroduce hard copies of the STGs in EML at primary healthcare facilities until a stable internet access, continuous and stable, and smart devices are accessible to all healthcare workers so that they can use the guidelines in their daily jobs. And this would improve rational drug use and patient outcomes ultimately. It's important to note the limitations of the study, that the study was conducted only at a public healthcare facilities where we use just one sub-district, so the results cannot be generalized. Questionnaires were self-administered and a response could thus be subjective. A lack of human resources and time constraints for participation in the research could have affected participants' responses. Prescription audit analysis relied heavily on record-keeping abilities. If poor recording occurred, then this could have impacted the results. And there are also very few studies of this nature, so it made it very difficult to compare our results with other studies. We concluded that the study did provide insight into the use and implementation of standard treatment guidelines and essential medicines lists to inform policies involved in the development and implementation of the NHI. There is a need for strengthening training on the tool and monitoring, as these guidelines will dictate the healthcare services rendered upon NHI implementation. The study may be replicated for a wider population to paint a national picture and to periodically assess the extent of the implementation of the STG EML to help measure the successes or shortcomings of the EML policies in the country. I'd like to acknowledge UKZN Drill and the South African Medical Research Council for funding my study. Thank you.
Thank you, Velisha, for your presentation. And as we said, we will discuss all this together. The question I would have liked to ask is the nurses and the doctors, they run independent clinics, I presume.
Sorry to interrupt, but we have the two other presenters on now. So I don't know whether you still want us to discuss before we take them.
No, let's take all of them.
Okay.
Let's take all of them. I've also noted that they have joined.
Yeah.
And let's hear all of them except Irenaeus, as I told you maybe before the meeting opened. I also confused the time, and now I need to leave. Please carry on with the moderation. I think we are on a right important topic. I'm one of the great fans of intersectoral club. Right. So please go on, next speaker. That's Shardrack Wanyina, sounds like from my place here. That's a familiar name, and I see other names I know they are from Makerere and Uganda. Please go ahead, Shardrack. You are muted. I can see that you are muted.
Oh, sorry about that, Prof. Good afternoon, good morning, and good evening, everyone here. My topic that I'm presenting today is
I think so. I can't hear him.
Yeah, we can't hear him. We can get the next presenter if he has got a connection issue now and come back to him later. Yeah, you are there. The next presenter, please load her slides or his slides while we wait. Sorry about that.
Yeah, I think that we are up next. This is Lisa Hirschhorn. I'm doing in behalf of Dr. Pillo Chillo, who's on the call but doesn't have good enough internet to present.
Yeah, thank you for standing in for him. Please go ahead. I hope your internet is better than the last one.
I'm hoping as well, but I'm cutting my video just in case. So I'm just waiting for the slides.
That's a good idea.
So Edwin, can you put up the slides?
I think you have something else in the background, perhaps. A bit not too clear.
Is that a focus issue?
There.
Oh, that's okay now.
Okay, great. Thank you so much. So I'm absolutely delighted, although somewhat sad, to be presenting this on behalf of Dr. Chillo, who is on the call and therefore will be available via chat to answer questions. And the rest of our team, this is a collaboration between Muhimbili University of Health and Allied Sciences in Dar es Salaam and the Feinberg School of Medicine in Northwestern University, Chicago. And it's a pilot project to measuring patient-reported outcomes in congestive heart failure using the Kansas City Cardiomyopathy Questionnaire in a tertiary care cardiology clinic in Dar es Salaam. Next slide, please. So what exactly are patient-reported outcomes, or PROs? This is defined as any report of the status of a patient's health condition that comes directly from the patient without interpretation of the patient's response by a clinician or anyone else. Quality of life or depression, but actually include a lot of other physical, mental, and social well-being components. Next slide, please. So the question is, and I come from a quality improvement background and was really trained in technical quality, is why should we measure PROMs, patient-reported outcome measures, and not just stick with our biomedical outcomes, the creatinine, the viral suppression, the blood pressure control? And the reason is it's really a core concept of people-centered healthcare, which we're recognizing is so important, particularly for primary care, for continuity and keeping people in care. Often as or even more important than the medical measures for making treatment choices and defining success. This is particularly true in chronic disease, where, for example, for congestive heart failure, we might be following the weight, but understanding their symptoms. You can choose to measure this with generic health status ones. Again, for example, depression or pain, doesn't matter what your underlying disease is, it's the same measure. Or you can use ones which are very diagnosis specific, a little bit more sensitive to the patient-reported symptoms that are associated with this. For example, congestive heart failure or arthritis. Next slide, please. So the problem is, that there's very limited research in actually integrating patient-reported outcome measures in Tanzania, with the exception of some very strong work that's been done around, for example, depression. And so what we wanted to do, recognizing the increase in non-communicable diseases and including in congestive heart failure, whether you could actually adapt both global and selected disease-specific patient-reported outcomes for patients with congestive heart failure, and importantly, to explore the feasibility and acceptability of measuring these patient-reported outcomes and the value from providers in a cardiology clinic, because basically, will they use them? And then this would be to inform development of an intervention to integrate patient-reported outcomes into a cardiology clinic care. Next slide, please. So the Kansas City Cardiomyopathy Questionnaire, or the KCCQ, is a validated measure that's been used in a large number of countries, but had not actually been used in Tanzania or actually been translated into Swahili. It measures symptom frequency, symptom burden, stability, physical limitations, social limitations, quality of life, and self-efficacy, their understanding of how to measure their congestive heart failure. The score is from 0 to 100. 100 is the best. When you look at the New York Heart Association functional class, so this is a very cruder measure of how people are doing. The best you can be is 3 or 4. The worst you can be is 3 or 4. So 85% of people who score below 25 are actually pretty severely disabled by it. And you can see as you get better in your symptoms, the score actually increases. So 80% who have scores over 75 are New York Health Association functional class 1 or 2, so that's limited. And what's nice is you can actually score using a full version, which is what we're going to present, the KCCQ 23, or looking at feasibility, the KCCQ 12, which is fewer questions, but has also been validated. Next question. Next slide, sorry. So this was a convenient sample of 60 adults coming in for care for congestive heart failure at Muhimbili Hospital Cardiology Clinic. We had limited numbers in who we could do the resources. This was a very, very small grant, but it also included a linked chart review for diagnoses, medications, and duration and care. We did know that we had 95% confidence interval plus or minus 10% to measure the PROs, assuming a response distribution of 50% for dichotomous outcomes, despite the 60. And I'll be presenting actually preliminary data to date, although we've just finished recruiting all 60. Next slide, please. So one of the most important things when you're using a tool that is validated, if it's validated in other settings, you really need to be careful about the translation, administration, and analysis. And this underwent a very rigorous translation, back translation, and pilot testing with what we call a cognitive debrief following their established protocol. The concept definition included the concept definition of the items in English, adaptation for specific countries using validated translations if those existed, dual both forward translation, reconciliation, and back translation, and resolution for languages where we could not leverage valid with 5 patients with cardiovascular disease. So giving it to them and saying, you answered this, what does this mean to you? And then finally, developer review. Once we had that translated and validated, it was administered by a trained researcher using a tablet for upload into REDCap. We also collected descriptive statistics to explore the range and variability of scores. And this was improved by both the in-country IRB as well as Northwestern, and informed consent was obtained from all patients. Next slide. So again, this is a presenting of the first 34 that were enrolled. We got a little bit of a late start due to the delays that I'm sure everybody is facing. 2/3 of the patients were male. Mean age was about 54, ranged from 24 up to 83. About 58% had completed primary school or less education, and 38% of them were employed. 24% of them were there with their initial visits for the congestive heart failure, and we noticed that about 1/4 of them had symptoms of depression at the clinic. There was a high rate of symptoms. 71% reported dyspnea, being short of breath, and 74% had edema. And 26 and 59% were AHA stage 2 and 3 respectively. So again, relatively significant burden of disease through traditional measures. Next slide. So what we found was, in terms of feasibility, this was able to be administered without need for explanation to the patients. We found that the average KCCQ-23 summary score was very low, it was 25.6. So if you remember, if you're less than 25, most people actually have very severe disease through the American Heart Association. This was worse among patients who came in with symptoms like shortness of breath or edema. We did not see any difference by gender, age, or whether or not this was their first visit to the clinic. Next slide, please. So what did we find by subscale? So again, there's a total symptom score, which takes account both the burden as well as the duration of the symptoms. Again, pretty low, 25. We found that limitations of social activities was actually the lowest scoring. So these were people who were really pretty constrained in what they could do. Physical limitations was a little bit better, but overall quality of life was not particularly good. But on the other hand, the self-efficacy was actually sort of right in the middle range, I think offering an opportunity to figure out how to even better engage these patients in the management of their own disease. Next slide, please. So again, this is the pilot results of a very rigorously translated KCCQ measure. We found that it was feasible and showed high evidence of disease burden and correlated actually with some of the more traditional physical signs and symptoms. Our next steps are to complete the survey administration, which has just been completed, courtesy of Jackson Millay, who's one of our collaborators, and planning to do a chart review to explore the relationship between clinical management and status with patient-reported outcome measures. We also are planning, again slightly delayed, to do key informant interviews with providers to understand their current knowledge, attitudes, and potential use of patient-reported outcome measures, and get some input into approaches to integrate PROMs into care. Doing this, learning from a lot of the work that's been done in other countries in terms of how to actually do this as a way for shared decision-making. And then finally, to develop an intervention in collaboration with the providers and the hospital quality improvement using co-design principles, and testing for initial implementation outcomes, feasibility, adoption, and fidelity. So are people, again, willing to use it? Are they actually acting on the PROMs? Are they using them correctly to inform some larger grant proposals for broader work? Next slide, please. So just in terms of acknowledgements, the KCCQ team, who generously provided the work to translate and validate the measure in Swahili, the Northwestern University Institute of Global Health for the catalyzer funding that actually supported our work here. Very importantly, the patients at the clinic who shared with us their reported outcomes, and the staff at the clinic who facilitated the research. And thank you very much, and open for questions in the next presentation.
Okay, thank you very much, Lisa. And then our first other two presenters, Dr. Dassah and then Velisha. So thankfully, we have Shardrack back on the call. So Shardrack, you have the floor to now present your, do your presentation. So do you want to share your slides, or we should say from our side?
No, let me share. I think I'm able.
Okay, great.
So
please go ahead.
Yeah, and I wish to apologize to the team for that hiccup. My computer just crashed from nowhere, but I was able to get another one.
Good. So, and then please remember that you can put your questions in the chat box, and then the presenters can as well respond over there as we listen to the last presentation.
Yeah, I had already mentioned the topic, and myself, I'm Shardrack Wanyina, presenter. I work with Makerere University Joint AIDS Program. This work I'm presenting has been attended to by a number of experts. As we can see, we have Dr. Martin Mudu, Dr. Priscilla Haguma, who are physicians in Makerere University Joint AIDS Program. And we have Scobia Enimbalinda, a senior lecturer in Makerere. We have Professor Elsie Chiguli Malwade, who also participated in this work. She's the Vice President of AfriHealth. And we have the PIs of this project. We all very well know, many of us know here that HIV continues to be a challenge in the health systems, especially in sub-Saharan Africa. And there is need for innovations that retool health workers for optimal response. So interprofessional education and practice has been one of the opportunities that we're trying to use to close gaps and address all this in the continuum of HIV care. And with the funding from UCSF, Makerere University established an interprofessional HIV training program. And this was in collaboration with other universities within different parts of Uganda, that is Kabale University, Clark International University, Sitema University, and Zambia University. And this is how the trainings were done in groups. This photo indicates during the pre-COVID-19 times, that was between September 2019 and February 2020. How the program was done, it targeted freshly graduated health professions of different cadres and involved those who are involved in HIV-related work in one way or the other. And it was packaged in a way that is a 2-day modular case-based HIV training sessions where we're using real clinical cases to facilitate the interprofessional training. And the facilitators included academicians and HIV experts from the 5 collaborating institutions, and also policy experts from Ministry of Health. And we did it in a way that these trainees were grouped between 8 to 10 participants with a mix of interprofessional group. And each group did complete 8 modules. And these modules included 4 co-infection, PMTCT and care of the pregnant woman with HIV, and care for the pediatric patient with HIV. So these 4 modules are the mandatory modules that this study focused on, and all trainees in this case were required to complete a pre and post test. And so our objective here is mainly to assess the improvement in knowledge based on the pre and post test scores. We determined the pre and test scores through the interprofessional trainees, and we measured knowledge gain using change in percentage score between the pre and post test by cadre. And then the results that we see here, we have, of course, in this period between September to September 2019 to February 2020, we trained 517 health workers. We can see this is the gender groupings around here. Majority were the female, and then these were different groups, the different cadres in terms of percentage. But out of this, 78% learners completed both the pre and post test, and this included 42% from the nursing fraternity, 37% were doctors, and 8% laboratory personnel, then 5% pharmacists, and 8% were a mix of other professions, including social scientists, data managers, people who deal with health data, and then health administrators were in this 8%. And here we see our mean score is 11% among all the modules. So these are the 4 modules, the core modules, and this is how the learners performed in the pre and post test. You can see the difference, some great improvements here, especially on this module 17. Yeah, so still looking at the results, the 4 core modules, in all the 4 core modules overall, the cadres scored as follows. We can see the personnel, 16% were laboratories from lab, and then pharmacists were 10%, and nurses 9%, and doctors 5%. Probably nurses, the doctors and nurses sometimes have a lot of knowledge with them on HIV and many other illnesses. Maybe sometimes the laboratory and pharmacists were left behind, but we can see that there is great improvement in the laboratory and pharmacists, 16% and 10% respectively. So the professions that had low baseline knowledge scores, here the lab and the pharmacists achieved more. They had more improvement as noted in the above results. The conclusion here is generally interprofessional HIV training improves knowledge among all cadres, and we notice here the laboratory professions performing so highly and gaining more levels of knowledge change. And so we recommend that this interprofessional approach should be considered for training health professions on the new Uganda HIV guidelines or any other guidelines as far as HIV implementation standard is concerned. Lastly, I just want to thank the team here and AfriHealth for giving us this opportunity to work with them all along, and also UCSF, and the opportunity to share our work with other universities. Thank you.
Okay, thank you very much, Shardrack. I think you've just been on time. So now we have still a few minutes more to the end of the session, but I don't see any questions in the chat box, sorry, in the Q&A box. If anybody has a question and would like to pose it, maybe we can get a question up for the presenters to respond to. And before we do that, we just like to again thank our 4 presenters for giving us such a very insightful presentations, and then also thank everybody too for your attendance. So if there is any question, we can spare the next few minutes to take it before we bring the session to a close.
This is Lisa Hirschhorn. Sorry, I can't quite figure out how to get something into the Q&A. Apologies for that. One would think after a year and a half, I would know everything about Zoom. I was fascinated, although not surprised as a physician, by the results of who sort of wanted to, the use of the, from South Africa, of ways of getting people to actually use the right drugs and use them properly, and the difference between the doctors and the nurses. And I was curious if there were any insights why physicians were less likely to use the tool than nurses, and what sort of insights or changes might be needed for that.
Okay. All right. So this question goes to the
Yeah.
Lisa. Okay,
Yes.
good. Yeah.
That's perfect. So the STG and EML was implemented for use in the public sector, and it was supposed to be mandatory use in the public sector to ensure the rational prescribing and rational use of medicines. And our study did not look at the reasons behind the non-compliance to the STG in EML, but and it would be interesting to see why doctors didn't prescribe according to the guideline. But we did see that when they when we looked at buyouts, there was a very small percentage of buyouts. So there could be in the study some bias towards or a skewed result in terms of the diagnosis being recorded in the charts. And that's what one of the limitations of the study is. But we didn't look into the reasons why. And I think that a strengthened monitoring and evaluation process would improve the implementation of the tool, because the tool has been successful in ensuring just a limited number of drugs treats the burden of disease in the country. So definitely strengthening the monitoring and evaluation of the implementation could possibly lead to an improved use of the STG and EML.
Okay. Thank you very much, Velisha, for the response. And there is an additional response to the question from Fatima, that doctors who have been found to want to use their own experiences and those of their mentors in prescribing. I mean, I think this is just in addition to Velisha's response to the question. Thank you very much, Fatima, for the contribution. So I don't see any further questions in our chat, our Q&A box, and I don't know whether there is any other question from a participant or a panelist. Okay, great. So on this note, we would like to thank everybody. So, okay, yeah. I think there's a question in the chat box. What do the schools taking strike plan to do after the period of strike is over? And I think this goes to Dr. Dassah and then also Shardrack. Maybe you can take your turns to respond to that question. So let me start first with Dr. Dassah.
Okay.
Yeah. Well, very interesting question, and I'm not really sure I have a definite answer to that, but I think that in the context of what is happening, and then the models that have been developed, and the fact that we've been able to transform these from in-person to virtual forms of training. And that had been our idea right from the onset, even before COVID, that we were developing an app that could spread, wide, so that you don't have to necessarily organize in-person training. So I do think that after this, it's possible to circulate that, and I'm sure from time to time people may call on us to have it, but it's something that we are all still discussing to see after Stripe what next. I don't have any definite answers. Thank you. I hope this is helpful.
All right, thank you very much, Dr. Dassah. Shardrack, would you want to respond to the question from the angle of
I could. Thank you so much. I could add in. Yeah, Fatima asked a very good question, and we as the Makerere team, we've been planning so much on issues of sustainability, because we know at one point the Stripe project will get done. But what we have done, one, of course, we started by piloting the LMS. We're one of those who are awarded for a pilot during the COVID times for 2 months, and our LMS has been working well for us. And we agreed with the USSF team that we maintain our LMS as Makerere, and this is a system that will continue enrolling learners with online. But what we are doing is trying to leverage with other programs that are already implementing in the PEPFAR implementation areas, PEPFAR supported sites, because mostly PEPFAR supports public sites. And we've also tried our level best to engage the ministry officials. In our team, we have part of our facilitators are from the Ministry of Health, the people who plan for the people who plan for the health services in the country. So we are trying to push it using other programs. And as Makerere as a program has a number of HIV implementation programs within the health facilities, within the district health offices. So we are channeling that through some of the regions, so that this training can be taken up by the ministry, and this kind of IPE training as one of the approaches to. And we're really trying to demonstrate that, because at the moment, we've targeted some PEPFAR supported sites that are not doing well on those specific indicators, especially indicators of retention in care, key populations. So we sieved out some of those PEPFAR sites that are not performing well in 2 districts, and we are offering the training. We are offering the training in modular form, but online. So we do this on weekly basis, and this is the last week that they are completing. After, we are going to continue giving them their mentorship online, and we'll base on the baseline. We got the baseline from the Ministry of Health. They're the ones that gave us the data and told us these sites are not performing well. So after some time, about 3 to 6 months, we'll be able to measure, especially the quarterly indicators, and see if there is some improvement. And if there is improvement, definitely we'll attribute this to the IPE training to some extent. And so in a way, we are trying to make the authorities buy it in, and also the country PEPFAR team to buy it in, to buy that kind of approach. Yeah, thank you.
Great, thank you very much, Shardrack. Clearly, engaging the leadership at that level is likely to make a difference. So we would like to thank everybody for attending this session, and then also more especially to the speakers, that we are very grateful for your very insightful presentations and then all the knowledge you've shared with us. And may we would like to invite the speakers to just put on your cameras for us to take a screenshot before we all go off. So Dr. Dassah, Velisha, and then Shardrack.
I think somebody's hand is up. Is it Velisha?
Okay, yes, this is Velisha. Velisha, you want to say something very quickly?
Someone at Afri Health Secretariat.
Yeah.
Yes, thank you. That was me. I just wanted to know if the cardiomyopathy questionnaire was freely available and adaptable even to other African countries.
Okay, all right.
Yeah, no, that's an excellent question. And Velisha, feel free to reach out to me. The answer is that if it's already been translated, then yes. If it hasn't been translated, then it actually requires a fair amount of discussion with the team. And they sort of took pity on us, and they did all the work for us for free. So that one, partially because then it would be available in Swahili. I don't know the other languages, but I'm happy to, if you reach out to me, just send me an email and I'll link you up with the team. They're very, very supportive and helpful in terms of figuring out how to further expand the use of the tool.
Lisa, can you please put your email address in the chat box?
Absolutely, and I'll try not to put any spelling errors, which is the...
Yeah, right. Thank you very much. So can we have all speakers put on their videos for us to take the screenshots? Good. Edwin and then Roger, if you are done.
Okay, so ready. We are done. Okay, all right. Thank you very much.
All right, thank you very much. Thank you, everybody.
Thanks.
And then see you in the next plenary session. We start in the next 15 minutes. Yeah, all right. Bye.